Hello and welcome. Today we'll be discussing the antimicrobial therapy for bloodstream infection in ICUs. Now, what is the definition of bloodstream infection? It is defined as microbial invasion of the bloodstream clinically identified by a positive blood culture in patient who show signs of infection. Now, how do I categorize bloodstream infections? First is the origin of the infection. It can be a community acquired infection or an hospital acquired infection, or it can be ICU acquired. Regarding the source, it can be secondary to an infection at some other source like a abdominal infection or a pneumonia, or it can be primary where we cannot actually identify a single source which pertains to the infection of the bloodstream. So how do the bloodstream infection affect the ICU patients? Critically ill patients often experience immune paresis, increasing their susceptibility to such infections. There is a high incidence of secondary infections in severe cases. Now, bloodstream infection is linked with very high mortalities, almost ranging up to 60%. Now, ICU bloodstream infections independently are associated with increased mortality as well as longer ICU stays. So, in the presentation, emphasis of antimicrobial management of bloodstream infection requiring ICU admission or acquired in the ICU. This is what we are going to focus in this particular presentation. Review the elements that are importance of microbiologic specimens, the timing and choice of the empirical antibiotic, spectrum and dosing optimization, necessity of source control, strategy to stop antimicrobial. So, coming first, what antimicrobial therapy to be given in these patients? So, the first thing that we do and practice mostly is an immediate administration of antibiotic. For ICU patients who are in sepsis or septic shock, the immediate administration of antimicrobials is recommended, ideally within the first hour of recognition of this thing. Now, impact of the timely management. So there have been various studies. The first one being the Kumar et al. In 2006, they observed a 12% increase in mortality for each hour delay in administering antimicrobials after we have seen an hypotension in septic shock. Andre et al. Reported 30% increase in mortality with inadequate treatment in the first 24 hours of a bloodstream infection. Bloss et al. Found that 2% increase in death per hour delay in antibiotics and a 1% increase per hour delay in source control in septic and septic shock patients. Now, there have been some contrasting approaches and outcomes. Ranjek et al. Compared aggressive versus conservative approach in ICU sepsis management, that is in patients without shock. The aggressive approach led to quicker treatment of fever and blood culture, but didn't always improve the clinical outcomes. The conservative approach resulted in more initial appropriate therapy, shorter duration of antibiotics, and lower mortality. So, in the aggressive approach, we try to give the broad spectrum antibiotic as soon as possible. The conservative approach says that you wait for some time, take a proper history, do the examination, and once you get some reports, you start your antimicrobial therapy after that. Now, the challenges in ICU. Now, it is very difficult to differentiate whether the patient is having an infection or an inflammation, because these patients are already in ICU and there are other numerous causes of non-infectious inflammations in which treating with antibiotics is not going to help. Delaying antibiotics to investigate the cause of sepsis can have benefits in lower severity cases, including avoiding the antibiotic usage. Now, the importance of diagnosing infection is very important. Now, the definitive clinical and microbiological diagnostic aids in providing targeted therapy thereby improve the outcomes. Now, there are a lot of controversy and observational biases in the study. The studies have shown that most of the benefits that we have seen are coming from observational studies. They underscore the clinical importance of early and appropriate antimicrobials. but then none of the approaches have been tested head to head in a randomized control trial. Thus, the knowledge that we currently have that we should be aggressive and giving antibiotics within the first hour, especially in the background of confusion regarding whether the patient actually has an infection or not, what could be the potential source of infection, which antibiotic could be appropriate, makes the decision very, very difficult. So a lot of work need to be done in finding out these particular things. The next is, if at all we are starting, what is the empirical regimen goal? The aim is to maximize adequacy, especially in shock patient. Be cautious of overusing, leading to harms like antimicrobial resistance. Now, targeted antibiotic usage, when the infection control source is known, use the antibiotic that are common for that source. So if you know that there is a pneumonia and it is a community acquired pneumonia, then it makes your task much easier. You target which organisms are going to be common and target them. Now consider patient's history, the setting of the molecule that you have chosen, especially in the setting of an MDR or any specific pathogen that you think of. Hospital acquired infection, you need to have a prior knowledge of the patient's colonization from the previous clinical and surveillance cultures to optimize your antibiotics choice. So the reports must be handy and you must have a clear-cut idea that these are the organisms that are colonizing the patient. This is the potential source of infection. So this could be the best antibiotic considering the tissue penetration and the drug susceptibility. Now, combination therapy. Provide a broad range against various pathological classes. Now, these include MRSA, antifungal, molecules targeting gram-negative bacteria. Now, used sparingly, considering it has significant risk factors, because if you are using all these agents, then there is a very high chance that there will be a development of resistance. Now, implement as a part of empirical regimen with a plan of subsequent de-escalation of the unnecessary components. Now, these are the potential infection organisms based on the source and the place from where the infection has been acquired. So, if it is a urinary infection from the community, you target these organisms. Similarly, for respiratory, intra-abdominal and intravascular catheters. So, if it is from hospital, your organism will slightly differ. Apart from that, you keep in mind the risk factors of multi-drug resistance bug, that is individual factors which you get from the history, whether there is recent hospitalization, antimicrobial exposure and other various factors. Apart from that, the current individual factors like how long the patient has been in the ICU, the severity of the illness right now. This is very important. If the severity of the illness is very high, which means that the patient is on high dose of vasopressors, you try to give the broadest possible cover instead of wasting time whether to find the patient is actually having an infection or not, what is the source of infection, all those things. And of course, if you know the colonizers, it makes your task a lot more easier. Apart from that, you need to take into factor the institutional factors, that what has been the prevalence of MDR in the particular hospital, regardless of the previous colonization. Taking all these things into account, you give the best and the most specific antibiotic for the source of the infection and the place of the infection. So, how do we do this? You have to make a differential diagnosis of what could be the reasons for this particular sepsis. It can be either primary or secondary. If secondary, then we need to know the source of this place. Microbiological results are crucial and they will help us in optimizing therapy, but unfortunately they are going to come later on, and if at all they will be positive or not, we are not very sure. Now, timing of the specimen collection is also very important. Send specimen before starting antimicrobials to avoid false negative, but logistically at times becomes very difficult. So don't waste time taking the culture if the patient is very sick. If you have the time, the patient is not sick, send your cultures, then give the antibiotics. Shear et al. Found that 50% positivity of cultures taken before antibiotics compared to 27.7 after starting antibiotics, which clearly shows that once you give the antibiotics, the probability that you're going to get a positive culture is going to be reduced. Now, impact of prior antibiotic therapy on culture positivity. Prior antibiotic therapy is an independent factor for negative blood culture. Positivity rate drops significantly, emphasizing a pre-antibiotic culture. Now, cultures in septic shock. Do not delay antimicrobial initiation beyond 15 to 45 minutes for culture collection. So, if you are able to draw the culture within 45 minutes, then you wait, take the culture, then give antibiotics. But if the patient is very sick, you don't have resources or logistics to send a blood culture within 15 to 30 minutes, then always give the antibiotic first, because sending the culture is always secondary. Saving the life of the patient is always more important. Now, obtain cultures from potential sources of infection like blood, urine or sputum. Try to find out what could be the possible source and send those cultures only. That would be always better. If it is pneumonia, then send the sputum or the ET culture along with a blood culture. You may not send a urine culture. Now, the sampling quality. Recommend at least 2 sets of aerobic and anaerobic culture. Adhere to strict skin disinfection, antiseptic technique to reduce false positivity. The latest technique, that is the molecular rapid diagnostic technique, can be used. It provides faster identification of pathogens and resistance pattern. The techniques like Malditov and systems like Accelerator Phenotype Automate Identification and AST give result within hours. The calometric assessment for detecting ESBLs and CPEs are accurate and inexpensive, aiding in rapid antibiotic escalation decisions. Now, reviewing the microbial results. Daily review the cultures essential for the patient to confirm the diagnosis of bloodstream infection. Treatment must be pathogen specific with adequate penetration into the site of infection with proper dosing and duration. Effective communication with the lab is very important. Regularly check in for results during the rounds. Laboratory alerts for positive cultures should be there in the hospital. Antimicrobial stewardship program and infectious disease rounds are essential to optimize the treatment. Now, antibiotic adjustment based on results. Now, once you get the culture results, antibiotics may start or de-escalate after the initial culture or gram stain result. For example, you have sent the ET culture, you have given both gram positive and gram negative cover. If the ET culture, if ET gram stain says that there is only gram negative, you can easily stop the gram positive cover. Further adjustment of pathogen in identification and resistance mechanism is important. Now, final adjustment is to be made when you get your final antibiogram. Now, antibiotic de-escalation involves narrowing the spectrum or stopping the unnecessary component. Now, reduce the broad spectrum antibiotic exposure and the antimicrobial resistance. Demonstrate patient safety and potentially improve outcomes. Specific pathogen and their treatment choices. Now, ESBL treated with carbapenems, alternatives are fluoroquinolones and trimethoprim sulfamethoxazole. AMC, cefepime is to be the preferred agent. Now, treatment considerations. Avoid piperacillin tazobactam for severe infections with either of these organisms. And new beta-lactam agents are effective but to be reserved for severe and resistant cases. For more detailed discussion on the specific organisms and what antibiotics you need to use, please see our previous videos where we have a detailed discussion on AMC, ESBL, SCRAB and Pseudomonas. Now, coming to Staph aureus and MRSA, require extensive antibiotic duration. So, in these infections, it is always better to give a longer duration of antibiotic compared to the gram negative, where we give for 5 to 7 days. Here you may need to give up to 2 weeks. Now, MSSA, treat with narrow spectrum anti-staphylococcal beta-lactams like a flucloxacillin. For MRSA, vancomycin is the first line, daptomycin is an alternative. The combination of daptomycin with ceftriaxone are rescue therapy for refractory MRSA bloodstream infection. Adjunctive rifampicin show no benefit in reducing treatment failure or recurrences. Now, importance of source control is very important, essential alongside antibiotic for treating the bloodstream infection. Urgent surgical or percutaneous management is needed for abscess, deep-seated infection and infected devices. So once you get a infection and you have the lines, then always change the lines first, treat the abscesses and remove the pus. The lack of source control is an independent predictor of mortality. Delay in source control is linked to persistent bloodstream infection and increase in mortality. Emphasize sending specimen for the infection foci during each intervention. If you are removing the pus, then please send it for culture sensitivity. Now, optimizing the dosing. Achieve sufficient antibiotic concentration at the infection site. So you need to know the penetration and the source of infection. Administer full initial loading dose. Do not adjust for renal impairment initially. This is very important. Do not adjust for renal impairment initially. You can do that after 24 to 48 hours. Sepsis alters pharmacokinetics of hydrophilic antibiotics, leading to change in distribution and clearance. So you must have clear knowledge whether the antibiotic that you are giving is hydrophilic or lipophilic. Augmented renal clearance is very important. So please dose your antibiotics adequately, otherwise you will underdose and it will result in failure and unlikely improvement in septic shock patients. Renal and hepatic dysfunction, use of renal replacement or ECMO impact antibiotic metabolism and elimination. Always take these into account for dosing parameters. Consider pharmacodynamic targets for all the antibiotics. Aminoglycoside, they require a high peak concentration with single daily dosing. Beta-lactam, they require time dependent, and fluoroquinolones and vancomycins, they are adjusted on the area of curve 0 to 24 divided by the MIC ratio. Now, prolonged infusion of beta-lactam is recommended after an initial bolus dosage. Follow the dosing recommendations that are there for the various antibiotics. For dosing recommendations, you can watch our summary video where we give the all dosages for all the antibiotics, especially when there is no renal impairment. So this is just a table showing the different antibiotics and their different methods of killing. Like the beta-lactam and clindamycin is time dependent, so they have to be given as an infusion for dosing intervals. Now for daptomycin and aminoglycoside, it is constant independent, so for aminoglycoside it is once daily dosing. For vancomycin and fluoroquinolones, linezolid, tigecycline, it is time and as well as concentration dependent. So use the AUC 0 to 24 by MIC curve. So when and how to stop the therapy, this is very important. Minimize the duration of cover, reduce the risk for adverse drug reaction and antimicrobial resistance. Evidence shows 7 days treatment is often sufficient for all uncomplicated gram-negative bloodstream infections. Now, criteria for treatment duration is consider patient's immune status, fever resolution, control of the infection source. Biomarkers like PCT, CRP can guide therapy duration. Repeat the blood cultures, unnecessary for uncomplicated gram-negative bloodstream infections, required for Staph aureus to ensure clearance. So, always remember when you are sending the repeat blood culture, why you are sending the repeat blood culture. Manage persisting bacteremia. In that case, investigate for missed source like a deep-seated abscess or endocarditis. Review and potentially remove the intravascular lines and the materials. Extend the antibiotic duration for incomplete source control or the persistence of the infection. So specific condition pathogens like longer treatment for empyema, brain abscess, joint infections or endocarditis. Staph aureus require at least 2 weeks of antibiotics. Complicated cases may require longer therapy. Candidemia typically require again 14 days after the first negative blood culture. Immune suppressed patients. In them special attention is required, longer duration might be necessary. Shorter therapies may be effective in some cases. So it's not that for all immunocompromised patients you have to take long duration. Take into account the various factors that we have already discussed before you prolong the therapy. Short treatment for specific infections. Like coagulase negative Staph aureus may need only 3 days of treatment for post catheter removal. Reevaluate the persistence of the symptoms. Consider other infection sites or non-infectious causes of persisting fever or hemodynamic instability, thorough differential diagnosis is needed before continuing or escalating antibiotics. So what is our take-home message? The take-home message is that first you do the initial assessment on day 1, perform an examination or imaging to determine where the severe infection is present and find the source of infection. Consider the risk of multi-drug resistant organisms based on the individual factors, the stay in ICU and the hospital factors. Collect the microbiological specimen, start the treatment. Begin with a probabilistic antibiotic treatment. If the source infection is known, implement source control, consider microbiological results. Add to the main antimicrobial regimen with need for different drug therapies like antifungal or antitubercular based on the symptoms and the presentations. Follow up. Between day 1 to day 2, check if the blood culture is coming positive and what are the gram stain results, and if you are molecular diagnostic, then check what are the molecular diagnostic results, adjust the treatment accordingly. And once you get the cultures, optimize your treatment, stop treatment if there is any unnecessary antibiotics being added, de-escalate your therapy, perform dose optimization based on the PK/PD parameters. Finally, establish a definitive treatment based on the clinical response and the treatment duration that you have given. Aim to minimize the duration of antibiotic. Most of the antibiotics should be given only for 7 days, and if you are extending, please make a differential diagnosis of why you need to extend, what is the possible organism that is causing this thing, and when you stop the antibiotics, stop it once you find the clinical symptoms have cleared and a source control has been done and the patient is showing clinical signs of improvement. If the patient doesn't show expected improvement, consider other causes of shock, reassess the infection management strategy, reassess your dosing, reassess your source of infection and various other parameters. So thank you for your patience, and you can follow this algorithm to optimize the antibiotic in bloodstream infections. Thank you.